Please
Good
start.
afternoon, all. At the outset, I would like to thank the organizers of AOS for giving me this wonderful opportunity to present this talk on scleritis nomenclature. Definition. Scleritis is defined clinically as well as histologically. Clinically as ischemia or vascular non-perfusion accompanied by the inflammation of the sclera with or without an active evidence of inflammation. Histologically, there is a granulomatous inflammation with fibrinoid necrosis within the layer of the sclera. So this is a typical case of scleral and episcleral inflammation, which beautifully resolves with topical treatment and oral NSAIDs. And we need to clearly notice the difference in the layers of the inflammation of the sclera, where the episcleral plexus are involved in the episcleritis, whereas the intrascleral and the scleral edema is very marked in the scleritis. We should also pay attention to the immobile vessels, which are very characteristic of the deep vascular plexus. That is the point to make a distinction of scleritis versus episcleritis. Peter Watson gave a beautiful classification of scleritis, which goes as episcleritis and scleritis, episcleritis as nodular and a diffuse variant. The scleritis is an anterior and posterior division. And anterior, we have a necrotizing with clinically evident inflammation and necrotizing without obvious clinical evidence of inflammation. Of course, there is controversy when we say without inflammation, that is obviously clinically seen evidence. So in anterior scleritis, we have a non-necrotizing, similar to episcleritis, we have a diffuse and a nodular subtype. When we have pan-uveitis, there is a similar entity among the practitioners called pan-scleritis with anterior and posterior sclera getting involved. McCluskey and Wakefield also gave a clinical grading of scleritis, which goes as 1, 2, 3, 4 in the grading of mild, moderate, and severe. And grade 4, we have a necrotizing scleritis with or without uveal show. In India, we all know that infections are super common. So scleritis seems to vary with the geography. If you read the Western articles, say the Bascom Palmer, you will come across saying that bacteria Pseudomonas aeruginosa being the super common etiology. And it was Jagdish Reddy from L.V. Prasad who came with the brilliant publication saying that scleral buckle was the commonest etiology. And he said that the fungal etiology is super common in the developing world. And it had a good prognosis when appropriately treated and with meticulous surgery. And they also came up with the recommendation that early intervention and appropriate antimicrobial treatment and debridement is essential. I thank Dr. Ratnam for sharing these slides. And these are the few cases of infectious scleritis I borrowed from her, which had a scleral abscess. Here the scedosporium was grown and beautifully resolved with end of 3.5 cylinder at the vision of 2025. This is another case of mixed staph with unidentified gram-negative, and obviously it had a poor prognosis with end ophthalmitis. This is a post-pterygium Pseudomonas, and with appropriate surgical debridement and amikacin, there was minimal improvement. And this is another case where with stick injury, the organism identified was alkali genes. And we were also able to see few other organisms like Enterococcus, like in this case. And there is marked improvement when we give an appropriate treatment like moxifloxacin. Something unique we also came across was an endogenous origin of scleritis, like in this case published by my teacher, Dr. Ratnam, with tubercular lung cavity identified in the CT scan. You see a huge elevation of the sclera with marked pus collections. And this is another case of nocardia, which had a poor prognosis with lung cavity and scleral abscess was sent for culture sensitivity, and we were able to identify it. Infectious scleritis could range from bacteria, fungi, viruses, and not to forget the parasites as well. And the point is to differentiate infectious from the non-infectious counterparts are the presence of purulent exudates, scleral ulcer, and characteristically hypopion should act as a pointer for the clinician. Of course, ruling out infection is very important in practice in developing countries. We also have necrotizing scleritis with inflammation, like we have an ischemia going on to necrosis, commonly seen in rheumatoid arthritis. We see a characteristic avascular area, which we should alert the clinician to for appropriate workup. If you can't measure it, you cannot improve it. So the grading of scleritis becomes very important. This is a pictorial grading, which grades from 0.5, 1, 2, 3, and 4. And in grade 4, there is diffuse redness with thinning and a scleral show. And AIOC of late has become really handy in the hands of clinician to capture both before and after treatment. As you can see, the beautiful, remarkable improvement of the intrascleral and the episcleral inflammation captured with the anterior segment optical coherence tomogram. The single most important point for scleritis is the presence or absence of interplexal edema. Why we need to fight for scleritis versus episcleritis is there is more common systemic association with scleritis. And this is again a picture from my mentors, where you see there is a deformity like this, diffuse scleral inflammation. And based on this image, you can say possibly there is a autoimmune association, or you should think in terms of relapsing polychondritis and other autoimmune etiologies. What could be the association? It could range from rheumatoid, relapsing polychondritis, SLE, antiphospholipid syndrome, vaginous, PAN, Cogan syndrome, or even ankylosing spondylitis, ulcerative colitis, polymyositis. The appropriate history should help the clinician. Not to forget, surgically induced scleritis has become popular, first identified by Argentin, and there is a necrosis at the site of scleral incision. This is my own picture where you are following small incision cataract surgery. There is a necrosis, as you can see, an up-down pupil with appropriate debridement as well as patch graft. You see a remarkable improvement, and we published this case report. Posterior scleritis is defined as inflammation of the sclera posterior to the ora serrata. It accounts for 2 to 12%. It is underestimated because, and here there is a characteristic subtenon fluid collection. This is my own picture where initially there was a choroidal elevation in one eye, and we did an FFA. It showed early hypo, late hyper. The blood count surprises. There is a remarkable improvement, increase in the WBCs, and we sent to the physician, and they were able to identify the BCR-ABL locus of CML and started on imitinib with hydroxyurea. And as you see, the other eye, there is a lot of SRF collection and suggestive of posterior scleritis, and the OCT was able to capture that. And following treatment with posterior subtenon along with imitinib, there is a remarkable improvement both on B-scan and OCT. So this is a myeloproliferative disorder. So we need to be very careful in ruling out masquerades as well as in scleritis. And this protein is coding for a tyrosine kinase, and the specific inhibitor really works. And the beauty of this case is, although in the accelerated phase and poor prognosis, we are able to achieve a vision of 6/6. And the pointers against the diagnosis of posterior scleritis, we should all know, is the severity of AC inflammation, dense KPs, posterior synechiae, as illustrated by Benson's article on posterior scleritis. What is new is the adalimumab, which is used by some of the authors like Dr. Padmamalini, has used in some of the cases of sclerouveitis and conjunctival ulcer. The take-home message is meticulous history taking, like uveitis, is very important. Localize the inflammation into anterior, posterior, or PAN, tailor-make the workup, revisit the diagnosis during recurrences. In India, we need to be very careful in ruling out infections before starting on high-dose steroids and immunosuppressants. Thank you.